So we're going to try and touch base with five different areas that COIN is interested in, of which the issue of carers is likely to be the biggest issue tonight of the five, partly because there's more people from the carer area here um, than other areas. What might be helpful at some point is to acknowledge that the issues we're discussing are always there, but very, very in your face and obvious at end of life. So end of life and palliative care people may be able to understand what the issues are, but they're not end of life issues. They're forever issues. And we may need to see how can we learn from people like you to make things happen way upstream. Um, the government's decision to move from hospital care to neighbourhoods provides us with a great opportunity to advance the ideas of collaborative working, multidisciplinary collaboration that COIN stands for. Um, the danger is that it will worsen the situation by increasingly medicalise things at local level, putting protocols and directives for every single aspect of life. And those of us who've been involved in the end of life sort of arena know something about people who arrive on the doorstep knowing nothing, think they know everything, and done something useful by telling people what to do. And now the danger is that that could happen at scale. And our job is to use all of our networks and influences and arguments to prevent that happening, and instead talk about neighbourhoods being enabling places where people can collaborate for health in all kind of directions. And we will keep on going back to that sort of theme as we go through the five kind of areas. We're working. Ellen Wright is the lead for South London RCGP faculty, and she's persuaded the other two London faculties to hold a City Health Conference, a London City Health Conference in June 2025, at which they will be looking at the issues that COIN discusses. Now, primary care networks. James Kingston will be here next month. He's traveling at the moment, and he oversees the CCCP, the Complete Care Community Programme, which is 65 primary care networks in the UK or England, I think, that are pilot sites for next stage thinking. He's very keen, very wedded to COIN, and we wish to help those primary care. But if anyone doesn't know, a primary care network is a cluster of general practices, usually meant to be around something like 50,000 population, that is meant to collaborate and promote health, not merely the interest of whoever joins the board. I am yet to see anywhere where primary care networks and public health neighbourhoods actually overlap and they actually work together on a shared agenda. But university roles and medical school curricula. Um, Look, what we're talking here is a very radical change away from medicine being merely the administration of medical science to being able to promoters of health, of which medical science is a part. And how do we prepare people for that at medical school and beyond, and not just doctors, but all healthcare workers? That involves a great active involvement of universities and schools. We'll get to schools maybe next year, I hope. And of course, the integration of primary care, social care, public health, and others at local level. And we'll perhaps touch on a little bit of that today.
My name is Sanjeev. I'm a GP in Barnet, North London. Been here for 20 plus years. But I'm also head of medicine at Anglia Ruskin University and professor of primary care and medical education. I think the kind of sort of broad brushstroke topic here is about medical curricula, or should I say healthcare workforce and integrated care, but also neighborhood care as well. I think the most important thing to say is that actually the relationship between medicine and its local footprint has always been limited. Um, if we take, for example, the established medical schools, their aspirations for supporting education and research, not just for a local, but for a national and international audience, has driven significant work at medical schools to create curricula that are appealing to and broadly speaking can be applied to any part of the country or any part of the globe. So I think that traditionally our focus at universities has been largely to develop a workforce for people to be able to work anywhere in the country, and for that matter, to attract talent from anywhere in the globe. And you know, the UK medical school environment has been incredibly successful, I think, at doing so, and is highly regarded internationally. However, the downside to this, or the flip side, or the other side of the coin on this one, is that actually creating creating universities that actually think about the local workforce need has always been, I think, a significant challenge. And I only need to look at my own backyard, which is North London, to know that the medical schools local to me do not provide a workforce to the local health economy. That's actually the relationship between medical schools and universities and local health economies needs significant strengthening. That actually local universities, particularly health faculties, really do need to engage with the agendas and with the requirements of the local healthcare workforce if we really want to start to see integrated care and neighbourhood teams emerge. The second thing is that actually, ultimately, if we really want to see retention and development of local workforce, we've got to also start thinking about recruiting and retaining people from local economies. And many medical schools will attract an audience from across the country. But actually, some of the newer medical schools are doing much more work to try and attract and keep the local talent in in the local health economy. The third is reaching out into the community itself, so working with schools and colleges and finding routes into medicine that allow local people to join the local medical school and even have a shortened medical program to accelerate through the program so that they're actually part of the local fabric of the community that they want to serve in the future. Um, and then there's a piece of work to be done, and I think this will only emerge over the coming year or so, where we need to start to think a little bit about what is the nature of localism and what does the nature of localism mean for medical care, for preventative care, and really for integrated care. And I think very largely we will be thinking much more about how do we provide whole person care? How do we provide team-based care? How does communication, reflection, um, and relationship management work in that kind of space? So those are some of the thoughts that I have. And one final comment I will make, Paul, is about the sort of there's a huge amount of money in life sciences, biomedical sciences, genomics, AI, a whole range of new technologies that is coming into existence. I mean, we're talking not billions, but we're talking trillions of pounds and dollars worth of investment coming to coming into healthcare. And one of the risks that that generates is the commoditization of healthcare, more, excuse me, more generally, and therefore a pressure to medicalize the population. Because otherwise, how are we going to pay for all this investment that is going into the development of new technologies? And really, it's been one that we need to grapple with. But someone earlier on mentioned public health. And it seems to me that actually, if we're going to optimize the benefits of genomics, for example, or AI, we have to also ensure that actually the relationship between these new technologies and public health and local government is strengthened and enhanced. Because actually, you know, if you get a test that tells you you're going to become a diabetic in 10 years' time, or you've got genetics that tell you that, you know, you're at risk of cardiac disease, actually the maximal impact of that kind of information only really comes when there's a partnership with local government to sort of start to tackle the things like green spaces, exercise policies, food strategies, housing, and education. They've all got to start coming together. So for me, there's something about these newer technologies that will be emerging through universities and through entrepreneurial engagements will only really have their maximal impact if the relationship between those technologies, those ways of thinking and doing, are aligned and closely working alongside public health strategies for improving outcomes as well. So there's some really exciting, I think, ways in which neighborhoods and integrated teams can really have quite a powerful impact upon the development of the workforce, but also the engagement with the sort of neighborhood based around public health and social care. So there's some really exciting thinking to be done, and we're only just starting on this journey, I'd say.
I totally agree with what Sanjeev has just said about public health. I mean, I would say that, wouldn't I? But I'm not an expert on this, but am I right? There is a whole branch of medical science called genetic epidemiology and population genetics. I mean, that really is combining genetics, but at the whole population level. So you really need to do the hard science bit, which is, what most people in genomics are doing. But you need, as you were saying, to join it up with what's happening at ground level across the whole population as well. So yes, I would agree with that.
It was just to say, I agree, Sanjay. What I would say is that genetic epidemiology is essentially looking at sort of as its name says, the epidemiology, where what I'm referring to is the therapeutic side of things. So as we start to see more genomic and other therapeutic interventions emerging, I think their benefit to individuals will only be realized if we start to take a population or a public health based approach to thinking about them. So if we take, for example, the announcement, I think it was last week or the week before, the Secretary of State announced how I think it was Greater Manchester will now be piloting a injection for weight loss, but actually they're going to be doing it with Greater Manchester rather than just in isolation. And my kind of sort of naive hope is that actually what they will be doing is not just looking at the medical intervention itself, but the broader interventions required to maximize the opportunity for health benefit by aligning that therapeutic intervention with a broader range of interventions around policy and other ways of thinking about health more broadly. And I think that actually the more we encourage new technologies, particularly at the level of intervention to emerge, that are aligned to public health and population health ways of thinking, the more likely we are to see the benefit of those interventions actually having significant impact.
Thank you. Um, Thank you, Sammy. You really you're talking my language, but around medical education and how it could be so much better if it was primary care based and localized. I'm sure you know Sam Everington. Yeah, because I was talking to Sam, and actually I think I published a conversation with him where he, never ashamed to be outrageously radical, he would like fast track, community based, diversely recruited, primary care based medical education to be the rule rather than the norm. So 3 years in the community and a year in a teaching hospital. He says any idiot can learn to replace a knee, but general practice is where the challenges are, and I agree with him. So he would say, and I think I knowing Sam, he will get this piloted, where local young men and women, or maybe not so young, will be recruited into local primary care based medical education, with the prospect of a 5-year term of practice at the end of it in their community, with an apprentice element, no doubt. And I think it could happen, and it should happen, and because this idea that healthcare is somehow generalizable, industrializable, cogs in the wheel, quality and guideline controlled, is the death knell of relational medicine. And if we're going to rescue it, I don't think it'll be rescued in teaching hospitals, and I don't think it'll be rescued by genomics. I think it'll be rescued by common sense and good politics, and I look forward to it. So that's the language I think we should be talking to. I deeply distrust high-tech prospects. It seems to me this is just the carbon capture fantasy of future healthcare.
And that is that I think that model has been actually used in Cuba, and we should look to see what their learning is. And another thing is, I know that Sam gives his personal mobile phone to patients who are dying at home. And let's, in all this clever working things out, not forget that actually you trust the people you trust and you don't trust the people you don't trust.
Hi everyone, Vicky Doyle. I'm based in Liverpool, run my own company, Capacity Development International. A lot of my work has been international, so mainly work in sub-Saharan Africa, looking at how to improve health equity and quality of care. More recently, been quite involved in tackling health equity challenges in Liverpool and the Liverpool City region, particularly looking at sort of how you can strengthen the community health system and the interface between community and primary healthcare. Liverpool is a city of, I think, rebels and partiers. They don't like to follow the rules, and that really came out very strongly during COVID. And there's still massive issues of mistrust, and it's how can we trying to tackle some of those issues and bring services to the community rather than the other way around. The work that we've been doing in Liverpool, was initially funded by Public Health, but working with primary care networks, and very much, recognizing that communities know their own communities best. So when it comes to trying to find hyper-localized solutions, you're far better working with people from those communities to come up with trying to tackle some of the avoidable unfair differences in health that we've been seeing in Liverpool, where depending on where you live in the city, there's a 15, 20-year difference in life expectancy. So then when you have standards saying like you'll have your healthy lung check age 55 to 75, if you live in Everton and Anfield, it's probably too late already because many people are already going to be dying at 55 from lung cancer. So this is where you need to have a much more localized approach to how you tackle these massive health inequities. And so a lot of the work we've been doing is very much about getting community organisations, people with lived experience, primary care networks, public health all working together, because there's so much silo working going on where people are not sharing their learning, they're not working together, they're competing with each other. And sometimes the politics is just quite outrageous as well, where you think, are we actually working towards the same aim? Surely we're all here to improve the health, health of people living in our local communities. And sometimes it doesn't seem that way. But very much the kind of the work we've been doing is very much about having these very much hyper-localized approach where you're working with community organisations, primary care and public health, and the neighbourhoods who are now, the neighbourhood model is very much being pushed in Liverpool now. And they're very much wanting to be part of the kind of approach that we've been developing with public health and the primary care networks.
Just hearing you talk, Vicky, two things. First of all, that idea of recruiting from your neighborhood, of course, it reminds me of my student days elective in Kenya. The doctors were having to look after, I don't know, 30,000, 100,000 people, but they could only do that by recruiting local assistants. And I'm sure you got loads of examples. But the other thing just triggers off what you were talking about, your difficulties of silos and people talking to each other. A recurring theme, which I encounter when listening to these or getting involved in these, is about scale. I think if it's striking, because of course in Ireland our scales are much lower, and I just wonder, does anybody ever look at scale? What is a, you seem to have huge organizations, huge networks, and it doesn't surprise me at all that people struggle to talk to each other and communicate and work together when the scale is so large.
Yvonne Lincoln and Egon Gruber from the States developed naturalistic inquiry, and from that to have the idea of fourth generation evaluation, which recognizes that the science, that medicine is aligned to, that sort of positivist idea of nuggets of truth, is only one paradigm of truth. And there are others, particularly critical theory and constructivism, that look at connections and co-evolution. And that the science of moving life forward in the complex, messy, interactive nature of society is very different from the science of positivism that medicine is up to its neck in. And I personally don't think we can tackle this issue of public health primary care unless the implications of that is understood and acted on.
I'm Neha Anakat. I'm the place director at Ealing Borough as part of the Northwest London Integrated Care Board. This conversation is really interesting because as we've been trying to think about integrated neighbourhood teams in Northwest London, in Ealing, we're on our third year of this journey of creating teams around our primary care networks. And the question of scale has come up. Right now, we're working on a principle that about 50 to 100,000 population is what we should focus our teams around. But I can't find anything to say that's the right population. I'm also really confused, and I'd be interested to hear if anybody has any thoughts on whether you need physical estate from which people are co-located, or is there a different way of making these networks work without a place where people can come together? And then the third bit, it's not only public health in London, the social care piece as well is so important for us. And I'm struggling to demonstrate what benefit it would give to some of our partners given their financial pressures that they have.
Yes, I work for a university and I'm at the University of Central Lancashire, where I'm now emeritus professor, and I headed up a programme and a centre called the Centre for Citizenship and Community, and I'm very interested in community engagement. My background is social work and social services, local government and central government, and I headed up in central government when I was working the National Programme for Social Inclusion and Mental Health. I would want to pick up and endorse the idea of smaller scale. I think the fetishization of scaling in the models we use to justify what practice should look like is often a major impediment. The whole research, the institutions of research disregard so much practice, so much evidence, at least kind of de facto evidence of useful community level practice, because it is argued it can't be scaled up. And the challenge of scaling it up is often held to as the gold standard, but we know that some of the best practice happens at a very kind of bronze standard level, and we need to really be supporting that and find ways of supporting that kind of level of change. And much of it is about good old-fashioned community building and community development, and these are the things that have been systematically squeezed out of the remit of certainly of local government. To pick up on what Neha has said, local government as a partner in this enterprise that we're talking about is to struggle, because local government has been systematically eviscerated in many parts of the UK, and what's gone from local government is the universality of it and the idea that it could apply itself. Social work could apply itself to small scale community building of the kind that ultimately promotes wellness and enables people to generate productive social networks through which they can get some ownership of their locality, make new social networks, grow in confidence, and be real partners in what we are talking about wanting to develop. So I just want to sort of throw in that as I don't know whether it's a note of caution, but I mean, because I feel as if this is a note of caution I've been raising whenever I've set foot in this group, and I don't want to be negative, but it does feel that we've a long way to go to resurrect the kind of precepts and practices of locality that were once associated with local government services. And I don't see government policy on health and the promotion of prevention saying very much at all about local government's role in this. And that bothers me. I think it's about trying to ensure that local authorities have greater capacity to play their role in catalyzing community engagement and community growth, really. I am on the board of a charity which is to do with walking. It's the Southwest Coast Path Association, and it's quite a good charity that links with lots of other charities. And I had an occasion to talk 2 days ago with somebody who is a community builder in South Devon, and she was explaining to me what she and her colleagues are doing to promote the engagement of people with walking, and through that with each other. And it's not, cliche rocket science. It's something which can be catalyzed by people in the right place who are not spending all their time chasing the money to do it. And it seems to me that we should be arguing for a greater role for locality in health promotion and in prevention, more importantly. And it just needs to be something which is recognized so that we don't go on talking about these alliances without actually recognizing that they don't come for free, and people need to be paid to do it. And we need to recruit people who can in turn generate these community networks from which we can develop our policy and practice around prevention.
That social workers, for example, in my experience, are trained mostly to identify problems, not to help people to help themselves. So they're looking for child abuse, not to help families to deal with dysfunction and pain. And that the the forum whereby local authority people and others can actually meet, well, they aren't there really.
Yeah, okay. So I'm a nurse practitioner and I work in East London in Bromley by Bow Health Partnership, and my role there is as complex integrated care lead. And I'm also the clinical lead for Network 6, which is 5 practices in North East London. So yes, quite a varied role at the moment. Yeah, it's just a comment really about the wider determinants of health. One of our GPs in the partnership, Saul Marmot, you probably know, introduced a project for all of our patients with long-term conditions to be asked about the wider determinants of health at every long-term conditions appointment that they came to. So as you can imagine, there was a lot of opposition to that because the nurses found it quite difficult to ask those questions and within the time. But it's gone on so that we're asking about loneliness and how does housing have any impact on your health? Are you digitally excluded? So that's gone from being an administrative task for the nursing team to do, and they found it really difficult, and they found it increasingly difficult when the patient says yes, they have got a problem with loneliness, they have got a problem with their housing. Who do they go to then? But fortunately, where we are, we have a fantastic social prescribing team that can pick a lot of that up. But they are increasingly now, because our referrals to them have gone through the roof, they're having trouble keeping up with it. So they would like to see a project where we work collaboratively. There's a live page where we can access that information without having to refer them to someone else. So, for example, if they needed help with finances, for example, we could direct them to the right place rather than it having all that information in one place with the social prescribers. But it's brought up some really interesting ideas and concepts that nurses don't feel comfortable broaching a lot of those conversations either. I think doctors maybe feel a bit easier. If you're having a patient in talking about depression or whatever, sometimes you will weave those discussions into your conversation. But I think nurses in particular found it really, really difficult. But it's been definitely worthwhile, and our patients are benefiting from it.
I know that what we're doing in the primary care clinics where I live and work here in Michigan in the US, we have started doing surveys around housing, food needs and transportation needs, and it's all being delivered as a survey. So every clinic visit, you get that survey, but it has already embedded in it the places that you can call if this is an issue. So the nurses don't have to deliver it and gather it as much as when you sign into the clinic, you already are given this in an iPad that delivers straight to the website for the information. So if people comfortable sharing it, they're already given that information. And it's a part of the community assessment tool that's being used in the local area. But actually, my question was really about IAPT services. When I was looking at IAPT services 10, 15 years ago, IAPT was discovering some of the same things in providing cognitive behavioral therapy at the local level. They were finding that a lot of the referrals they needed to make were for social issues like housing and need for legal support. Is there anything we can learn from the delivery and the broad delivery of IAPT services a decade ago at the local level to social prescribing issues that could be reapplied now?
I think, what do we mean by community and neighborhood? And you can't really have large scale in the same sentence. It's nonsense. Neighborhoods and communities are necessarily quite small. So that's I just want to get some common sense into these ideas where I think these words are being hijacked.
What is a community? What is it that binds people together? Networks of relationships, and rather than this, a notional academic thought of a chunk of people.
The first thought that comes to mind is that actually over the last 30 years, there has been a systematic denudation of localism and neighborhoods. And that centralization of power, resource, capability, and thinking. The consequence of which is that even definitions of what is neighborhood and how neighborhoods function are actually centrally managed. They're not even allowed to have agency unless that is given to local communities by centre. So even if you take the idea of devolution, which is meant to be an attempt at trying to encourage greater agency at reasonably local footprints, actually that's an agenda that is largely driven and delivered by national government. So actually we've lost the ability to be agentic at a very local level. And I think that's really important, because what it means is that actually the capacity and capability of defining our own neighborhood and its health system is actually largely, we're just waiting for policy to emerge. And actually that's how bad the situation has got, is that we are now utterly dependent upon a centralized monotheistic entity that it smothers our ability to be able to do that. So I just wanted to flag that, because I think that's kind of all pervasive and is very difficult to break out of, but does require governments actively giving up power and making agency available to local communities. The second thing I think that's really important when you think about universities and their ability to to move beyond first and second order knowledge creation, particularly to third order knowledge creation. That requires universities working in very, very local situations, accepting that what they create as new knowledge is not decontextualized, is not publishable, but only has meaning to those that actually live and breathe that knowledge in the here and now, which will inevitably break and fall when that circumstance, local circumstance changes. I would say that actually we've already done community-based education from year 1 to year 5 in bits of Northeast London. I was leading that pilot with Sam, of all people, and we were stopped from being able to pursue it further because it was just not seen as the right thing to do, even though it was absolutely the right thing to do. I think you've got to have physical estate. We've got to bring people together. We've got to be seen to be working in 3 and 4 dimensions rather than in this kind of 2-dimensional way. It's got to be one and the other, not one or the other. And the final thing I would say is about co-creation, that actually knowledge creation and how to create knowledge for a local community requires an engagement with that local community. So what matters in terms of access to healthcare for inclusion health communities is going to be determined by the makeup and the nature of those inclusion health communities. And if we then don't teach our medical students and nursing students and others to engage with that type of knowledge, we're then not creating a workforce for that local community. And that's why actually curricula and teaching methods need to be co-designed with the local populations that they're seeking to try and serve. But if you don't first direct those entities towards being part of a local community, they always will struggle to find their place in that space.
That sounded like a manifesto to me.
It did.
Why don't we write one?
Yep. Look, I remember David Colin-Tomey, another person who can't be here today. He was 10 years the National Programme Director for Primary Care. And I remember having a conversation with him once, and I said something like, isn't it amazing that schools can produce people to go into medicine who are some of the most intellectually able and altruistic of their generation? And then before I could finish, he said, and we ruin them. And we laughed, but that's quite a serious thing, isn't it? Because that's exactly what we're doing. And when my wife was dying, the 2 schools that my kids were involved with became the places of support better than anywhere else. The network of community that revolved around my house were effectively the families of the children, and the teachers facilitated them to befriend each other and support each other. The roles of schools in all this is potentially enormous.
Marketing and operations manager at the British Association for Holistic Medicine and Healthcare. Another hat, I'm a death doula. I work with people at the end of life. I work on a local community project working with, I live in St Albans in the UK, which is, allegedly one of the 5th happiest and wealthiest places in the world, and 60% of children live in poverty. I've been working on this project for, I don't know, about 8-9 months now. There are massive barriers to health and social care.
I used to teach. I'm now retired. I do various roles in primary and social healthcare. Central London community healthcare. It started off in Central London but spread. So it goes out as far as Hertfordshire now, for example. And it does a number of different things, but the area in which Paul and I are involved is the operational group for end-of-life care. I'm supposed to be representing ordinary patients, and I also do work at my local hospice for bereavement support, and I sit in on their nurses group report backs every month.
carers are something like but 10% of the population. In certain age groups, it's more like 20% of the population. And they're often unprepared, unsupported, don't know what they're doing. And even when they do a very, very good job, run into all kinds of difficulties that are probably preventable or at least ameliorable if there was better teamwork and support and understanding of the complexity they're in. And very often their work gets medicalised. They get told what to do by various protocols, even those protocols haven't got the faintest clue about what's going on. Along come people full of ideas about what the carer should be doing and land that on them and then go away and make safeguarding complaints when they don't adhere to them. And this is an everyday issue. I've heard this now so many times that this is kind of what happens. So how about developing a course for carers where they're able to prepare themselves not just for the medical aspects of feeding and moving, but for things like managing complexity moving into the future, developing a compassionate community around their home, about preparing themselves to learn through the experience of caring, such that when the caring role is over, they're not just themselves about to collapse in a heap, but are ready to move the next steps forward and become, in a way, part of the glue of society. Now, these carers already exist. And the GPs already exist, the palliative care nurses, the undertakers, the pharmacists, the social workers, they already exist and they're already serving these people. The trouble is everyone's duplicating each other's work and everyone's focused on what people should be doing instead of forming a united care community, a professional community around that group, around that household. So the proposal is that there's, on the one hand, a continuous ongoing action learning set for carers in a particular road or area, where they are able to share their ideas that are facilitated by somebody who's not necessarily very knowledgeable about anything very much, but good at convening meetings, perhaps primed by some of these things about thinking beyond the medical model, about, how do you think about, stress and respite and so on. So that's going to be piloted with Brent carers who aren't here today. They're involved and with CLCH.
I couldn't do my job without the carers, and I just have so much respect for them. And there just isn't enough, there's never enough hours in the day to give everyone what they need. I mean, I think for us at our practice, we give them a point of contact. We now have the care coordinators who are like a buffer from us, but they're there every day, and they're a point of contact for patients that are at end of life or with dementia or are very complex. So our care coordinators are not medical. They've usually they've had extra training to be the first port of call, and they can answer an awful lot of queries without us being there, but they build up a relationship with the carers. And we also do as clinicians as well. But my hat off to them. I spoke to a lady the other day on Monday, and I just don't know how she's doing it. So and it's about not just hearing that and bearing witness to it and just thank you, you're doing absolutely amazing. And just having that conversation with them and not rushing them off after 10 minutes. So we do try and give them an extra time in the consultations. For those particular patients, I have 40-minute slots, which some people think, oh my goodness, that's such a long time, but it takes that long to take your time and go through things and not make the patient feel or the carer feel rushed. But in terms of getting them together, I'm not sure how that would work. I don't know how. Yeah, I think it's a great idea. There's lots of unpaid carers. There's lots of paid carers that I think would benefit from that. Yeah, I'd like to. I'm a bit of a logistics girl, so I'd like to see how it would work. But I think it would be great if that could be brought ahead. And things like advertising. How would you make people aware of what was happening? Because fine if everybody was on one street, but our network we're all over the place. So we've got 17,000 patients in our practice and 70,000 in the network now. So how do you pin that down to one street, or how do you find these patients who they are? I'm sure
Hi, I'm Lee Valance. My day job, I'm a chief exec here in Bolton Hospice. I chair the Greater Manchester Hospices Provider Collaborative, and I sit on the Greater Manchester NHS Integrated Care Board as a representative for the voluntary community and social enterprise sector. In relation to carers and the messages that we can share, I think it's to identify what already exists and what already works, and but it isn't seen or isn't spoken about. So, for example, in my hospice, obviously, we support the family members and carers of use our wellbeing hub as well as our end of life care services. As well as being able to support them with the practicalities and a whole range of other issues, we're also able to provide direction about future steps and life beyond bereavement. And there's like a virtuous circle for many of the people who then become volunteers. So they become active and engaged. So all within one organisation. And that happens in many places across the patch. It's not just hospices, but we don't really have that knowledge. We don't really have that intelligence. But there's a lot of good things happening, but it's about how do you capture it, how do you articulate it, but then how do you support its growth?
So I am currently based in the US, so grain of salt for where I'm coming from. But I've been working with family members, having been a family nurse practitioner and a nurse and a hospice volunteer. I'm in the process of bringing carers online with 4 different families in 4 different cities in 2 different states. And one is through hospice, but the others are more about dementia care. And so part of the issue is the cost, certainly in the US, that the good carers can be found, but it's out of pocket. And so families are trying to figure out how to, when they actually need somebody full-time in the house with a family member, there is a cost concern. So that's one problem that I think we need to solve for on a policy level. As far as training, some are better than others at having the social skills and the wisdom for being creative and creative problem solving. So while there are some basic skills that we teach nursing assistants and also teach carers for how to lift and move and be safe with their clients, the ability to be creative with somebody with dementia is an unimaginably hard skill to teach. And you know it when you see it. You know that somebody has the ability to shift quickly in somebody's world that's agitated. And so I think some part of the training program needs to have these adaptive skills for working with clients in their homes and finding creative solutions, which also means working not just with the client, but the family. So some part of the training is actually teaching the family members how to use and work with and collaborate with carers, because not every family member needs to do that. I'm spending an inordinate amount of time with spouses trying to teach them how to let a carer help you. And I think there's some conscious training that has to happen in any kind of programming kind of way. Dementia is a huge piece of where our population and healthcare needs are heading in every society. So while hospice is the obvious way of how care at home happens, complex conditions are an obvious way where care at home needs to happen. The needs for somebody with profound dementia, who's going to be with us for many, many years, is a part of the training that needs to be acknowledged, and a set of skills need to be there in the behavioral health kind of way.
Giving people permission to do things that aren't necessarily inside the book. Graciela, a professional carer who may still even now join us, but is working at the moment with a client, told me this lovely story of her own when she was working with a demented care client. who got very, 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 very angry and was wanted to assault her and everything. And the son was there as well, and they were trying to calm. So what she did was they went upstairs and changed their shirts to a different color, put a different jumper on. They came downstairs, and the lady they were looking after said, "Well, where's that woman? That woman with the black top? I really want to kill her." And now, because she was wearing a white top and didn't recognize it was exactly the same person. And then she said, "No, I think she's gone now. But now, how you look really well, like a cup of tea." And that's an extreme, sort of disallowable thing to do. But when you're dealing with somebody who can't actually make the cognition that you want, you need to be given permission to do those kind of things that are outside the book.
Thanks, Paul. I just wanted to throw in very quickly just the acute community kind of issue. You know, the strength of the acute sector and in sort of most of the discussion that we've had this evening, and just how powerful, you know, the acute side is, which kind of makes the primary community setting quite a difficult ask. And you know, with primary care and community care suffers from, you know, all those different names that you mentioned, Paul: primary care home, primary care networks. We've now got integrated neighbourhood teams. But the strength of the acute side, you know, is just sort of there subsisting. And there's just an issue about how, you know, you draw that down. And of course, you might get, you know, down to some contracting at the end of the day to look at that and to make sure that money flows, you know, where, you know, this group wants it to go. And that's not easy, where community groups are under pressure to keep their contracts, and, you know, just to the VCO sort of sector struggling to get the grants to keep them in business and so on. So
we've touched on so many things that I'm trying to assimilate it all. Just a word about Wes Streeting. He seems to be, secretaries of state generally seem to think that they can run the show, and lots of people expect them to. Whereas I'm sure that a lot of people will agree that you actually need to empower people further down, and as far down as you possibly can in a hierarchy. And I'm really interested in the way that people have been talking about empowering carers and teams and the like, and the number of different examples. So I am naturally a fan of that. And I suppose what I'm going to take away from this is a lot of thinking about rethinking, and Sanjeev's intervention, which is Steve's quite right, it is a manifesto, really needs writing down and setting down and looking at very much more closely, because it is a very radical rethink of how we experience training and practice and management in healthcare today. And I was very interested, as I've been talking to a team about volunteering quite a lot, as well as doing some volunteering myself these days, about how people get into volunteering. And it's often when they start caring in a care home, for instance, a relative they might be therefore dies, and they carry on volunteering in a care home. That's just one example. And where there's a recognition of the person's own needs to be a carer and to be valued as such, and being able to give to somebody else or a community of practice, and how we need to put these things together rather than separate them out. And I think about the industrialization of primary care. Someone mentioned the commoditation. It's the same difference, I think, where we separate out and we transactionalize, and we need to stand up and state another way of looking at things and another way of defining care, actually, and of understanding what it means to give care, to receive care, and what care ultimately is about.
A lot of this conversation is floated around end-of-life care. When we piloted the course for carers on end-of-life care, we quite quickly realized it was far too late to start helping people at that stage to learn how to be a carer. They needed to do it decades beforehand. trouble is, decades beforehand, people aren't ready to acknowledge that they need help. It's almost when they hit the buffers that they recognize they needed to have started this 20 years beforehand. Your reflections on that?
I think that's absolutely right. And as individuals, as we get older, we think we're invincible until suddenly we aren't. And that's a neighbour of mine who ended up in A&E just before the weekend, said she was devastated because suddenly she realised how vulnerable she was. And that's just one example, but that happens all the time. People go into caring as family carers. Without any knowledge of it. They do it because they think that's what they should be doing, which is absolutely fine. And they have to learn on the job and become experts. And some sink and some swim, and most do some of both. And it is partly the job of healthcare professionals to validate the role of the carer, to do a bit of education, um, uh, and so on. But most importantly, to validate and listen to the carer's side, which immediately brings in the team, and the extended team, which has the patient in the center and the family carers as well as the healthcare professionals. And it seems to me, I think about this time and time again, and it makes complete sense to me, and I can't understand why nobody else understands it. You know, that's the usual story. But I don't think people do think about becoming carers until the role is presented to them, and then they just get into it without saying, I want to do this or I don't. They just do it. And I think we have to accept that that's what happens so much of the time. Some people are more amenable to being a carer, and I'm very interested that many more people who work in healthcare are also informal family carers. I think that says something very important. But I think we have to be ready to catch people when they first walk onto that stage of being a carer and to say, how can I help you? What can I teach you? What can I learn from you?
We need to normalize caring, accept that it's an important role inside society, and recognize much, much earlier. And I know that the local corner shops, the pharmacists, the undertakers, the next door neighbors understand all of this, but they're not actually given permission to say, oh, you must be a carer. Is there anything I can do to help? Or do you want help with your, prescriptions being sent to you rather than picked up or whatever? Would like a place. The local undertaker has offered a room where people can meet, for example. And I think if we can normalise it and catch people a lot earlier, using the experience and understanding of people further down the road, like palliative care people, we may have the opportunity of making this happen at scale earlier as well. My own view is that this needs to start at schools. It needs to be part of the preparation for medical schools, inside medical schools, normalized throughout society, and then end-of-life care starts becoming a natural part of that when it all suddenly makes sense. But you're talking about citywide interventions, collaborations to develop across whole towns, whole cities that promote healthy neighbourhoods, that perhaps is guidance to Wes Streeting about how it all can work from a city perspective.
Maybe I can just talk a little bit about the work we've been doing in Liverpool, which is now being expanded to the Liverpool City region. The basis of it came from our work in Kenya, where we've been working with community health volunteers who barely get paid anything. And this is one of the things I get quite angry about, is that we often, the assets we have in the community, we use them and we have to stop using them, and we need to value them and remunerate them as well for the work they do. But so we were very inspired by the work we've done in Kenya, which has been working with small communities who are linked to primary healthcare centres. We've worked with them in giving them the basic skills to use their local data to then come up with their own solutions, back to the very premise that communities know their communities best, the very hyper-localised approach. we were approached by the Director of Public Health in Liverpool during COVID because people weren't going for vaccination. They tried, healthcare providers had tried to do everything. People were still not engaging. And so we were asked to sort of use models that we'd used in sub-Saharan Africa, working with, I suppose, what are termed hard to reach populations, which again, I hate that term as well. I would say they're hardly reached rather than hard to reach, because again, we often put the blame on the communities, whereas actually it's just inability of health providers and leaders to actually listen to communities and understand what communities need and want. So we've worked across Liverpool, working with primary care networks, with community organisations, people with lived experience, community champions, but also with creatives. And I think none of us have spoken about creatives or artists as well, because again, I think one of the I'll give you the example of the work we were doing with very low uptake of breast cancer screening in North Liverpool. Less than 50% of women are going for breast screening. When you speak to the breast screening unit, they say we provide a perfect radiological service. Our services are wonderful. We meet all the standards. And I said, well, with all due respect, they may be, but if less than half of the population of eligible women are actually engaging with it, you've got a problem. You need to find other ways of reaching that community. And that's where we worked with creatives, with and I suppose influencers, poets, to try and find a more community-oriented way of reaching those communities. So I think it's trying to get away from that over-medicalisation. When you get a very clinical letter saying you need to have your breast screening, you're due your breast screening appointment, people don't want to engage with that. Everyone knows someone who's had breast cancer. Everyone knows someone who's suffered. Whereas if you can kind of explain it in a much more humane way, add a bit of humour, you may actually be able to talk and go out to communities and talk to people in their own communities about what it is and speak to people in their own communities in their own language. You're far more likely to get that engagement. So the work we've been doing is very much having a far more, I suppose, collaborative approach, trying to break down some of those silos, getting primary care, public health, creatives, community all working together, using their own data. And I think the important thing is also getting those insights from the community as to the reasons they don't want to engage with health services, and then coming up with local solutions. We've done that within Liverpool. We're now expanding it to Knowsley and Sefton. This is all on trying to tackle health inequity, which, as we know, inequities are getting bigger. And I think public health, because we've talked a lot about the role of public health. I think they really do want to do something. But I think often the local policymakers, local government, they're so busy providing statutory services. They also don't actually always know what to do or how to be more innovative and how to try and do things differently. It's clear that, certainly in Liverpool, and I think in many other inner cities, we're seeing those gaps and those inequalities getting bigger and bigger, which does require doing things differently. But then I think sometimes you need that hyper-localized approach of giving these very practical, real examples on the ground of how you can make a difference to actually start trying to do things differently. I think what has come out very importantly is like team leadership, and that's when you've got good GPs who get it, when you've got community organisations who are trusted within their own communities who are supporting it, I think you can really start seeing a difference. When you value the community assets themselves and don't use them, then again, we can see change coming about. I think public health systems have to be a lot more flexible in how they work and recognising that one size does not fit all. I think we've seen also in this work the importance of shared leadership between public sector and communities. And I think it does require the public sector sometimes having to let go a bit and letting communities get on and do things the way they think will work for them. And I think that's very hard. I think when you're running it within a project, you can take risks and be innovative. And sometimes that's the power of having these, I suppose, smaller scale projects to try and to demonstrate that change is possible. I think what we've tried to, again, what we've been trying to do is leverage existing resources. And as I said, this trying to break down that silo working by making sure that the community innovation teams and the work they've been doing, they sit on some of these different structures within local governments to, I suppose, feedback what they're doing and to share learning. Because again, there's not enough shared learning going on. So I think what we've been doing is very simple, practical steps. There's no rocket science here. It's about using local data, combining it with community insights, empowering communities to come up with their own solutions, and then supporting them to implement their own solutions. We've now sort of expanded, but very much using I think the creative health approach has also been really important within that. We now have funding from the Arts and Humanities Research Council, so we've kind of expanded this a bit more to go wider than just Liverpool. Again, with support from public health and in Liverpool with the neighbourhood model as well, to look at how this can, I suppose, be done at a larger scale, but very much still, I think, focused on health equity. And each of these teams have been just tackling one issue at a time. So trying not to overcomplicate it, because some of these health inequities are so massive. And so we've been working on cancer screening, immunisation uptake, and now moving into social and mental wellbeing, which is going to be, I think, probably a bit more difficult. I think the biggest challenge, though, is providing evidence. We had that discussion a bit earlier about what is evidence, and commissioners want different types of evidence to probably what the kinds of evidence that communities provide. And I think that is one of our biggest challenges. We talked about in our work the kind of metrics that we've seen in our work. And yes, you can hopefully show there's been increased engagement and uptake of preventive and promotive health services. But I think it's also the fact you're seeing new networks, new stakeholders working together. You're seeing increased capacity of community organisations to actually advocate for and act on health inequity. We're seeing new conversations and changes in language. We're seeing enhanced teamwork between the NHS and community organisations. And I think we've tried to engage with policymakers or local decision makers by, sharing with them and getting them to engage in the process. But I think sometimes those kind of impacts don't get seen as impacts, and all they want to see is harder evidence. And I think it's how you can convince policymakers and commissioners that this type of approach does have an impact, and trying to get them to look beyond the normal metrics.
The conversation's been very illuminating and really covers the spectrum of all of the challenges that are discussed within an integrated care board and a system. That this is going to be a bit of a stream of consciousness. That I think it's really powerful to have a group of people like this doing some of the thinking to see how can we do things differently and how can we communicate to the system, how we can make the connection between big strategy and actually making a difference on the ground. And therein lies the big challenge with the integrated care agenda, and the fact that the NHS element of it, the integrated care board element of it, is very much under the cost of NHS England. And the primary focus has been on cost saving. And on top of the cost saving, you've also need to find ways of delivering things differently so we can get funding out of acute and into community. And how do you do that? How do you face in two directions at the same time? And the cognitive dissonance that's having, the impact of that on people's heads. They don't have the headspace to do the thinking that's happening in this group. They're under tremendous, phenomenal pressure to be able to deliver those cost savings, facing a growing gap of health inequalities, growing demands. Also, this week we heard the data around the drop in the birth rate. So we know what's coming down the road is actually getting worse. So we have to do things differently. But having the big strategy and the big thinking, there is still a massive disconnect. And we haven't got to grips with system working, how we manage those risks, how we let go. Actually, there needs to be a lot of letting go and letting people get on and do these changes. So I think the will is there, it's the how. And the how is that much more difficult when you've got the battle around resources. So that's the big headache at the minute. But this group is really, really powerful because it's starting to do that discussion of there is lots of how, there is lots of ways of doing it. We just need to connect it all together. And that's not going to happen at pace, not at the pace that we need. Places, I know in GM, we're very much taking an approach around commissioning that's about co-production, and it's about empowering and getting down to the grassroots. But translating that into actual action is a real challenge that I don't have the answer to, but maybe you guys do.